Hello, my name is Dr. Daniel Popowich. I'm the Chief of Colon and Rectal Surgery at St. Francis Hospital in Rosyln, Long Island, part of the Catholic Health Services. I'm going to give a lecture today on the current trends in the surgical management of ulcerative colitis. During these days where a lot of us are not doing any clinical work, I think it's very important that we continue to try to educate and collaborate with each other. And I congratulate Dr. Eric Pauli for putting this together and for inviting me to give this talk. These are my disclosures, none of which are relevant to today's talk. The background of ulcerative colitis is that, along with Crohn's disease, those two diseases, they are classified as inflammatory bowel disease. They make up more than 99% of all disease processes that would be classified as inflammatory bowel disease. There are also things like microcytic and lymphocytic colitis, but that's not relevant to today's talk. What distinguishes ulcerative colitis from Crohn's disease is that the pathology is limited to the mucosa of the colon. So it's a mucosal disease. It begins in the rectum at the dentate line, and it will extend for varying distances proximally. Whereas in Crohn's disease, it can be full thickness through the bowel wall, and it can affect any part of the bowel from the mouth to the anus. The causes are largely unknown and likely multifactorial, but there are certainly genetic predisposing factors, there are environmental factors, inflammation, things that cause inflammation like smoking, and it is also considered to be an autoimmune disease. The incidence and prevalence might overall look like there's a very low number of the patient population, but we're actually finding that the incidence has been slowly increasing, and there are a lot of patients out there with vague abdominal symptoms who might not have brought themselves to their doctor's attention, who actually have more quiescent forms of the disease. But the peak incidences are reported in young adults, usually teens, 20s, and 30s. There is a second peak that occurs between the ages of 50s and 70s, where patients were completely fine their entire life and then all of a sudden can present with pretty fulminant ulcerative colitis. It's more common in North America and Europe, those which are considered to be the temperate climates. It is more common among Caucasians and Jewish populations, and there is slight male over female preponderance. The genetic predisposition is largely suspected and has been subsequently proven because upwards of 1/4 of patients with inflammatory bowel disease will have other family members, first degree family members, with inflammatory bowel disease. The disease distribution varies, but more than 80% of patients will only have left-sided disease, meaning limited to splenic flexure and below, where 40% will only be rectosigmoid or ulcerative proctitis, and another 40% will be the entire left side of the colon. Only about 20% of patients will develop full pancolitis at any time during their disease distribution in their disease course. Progression, meaning disease going from left-sided to pancolitis, occurs upwards of 50% of the time, and regression occurs about 75% of the time. Regression is largely associated with the institution and the efficacy of medical therapy. The gross features of the findings in the colon are actually quite stark and remarkable and very classic. On the left here, you see a total proctocolectomy specimen. So this is a patient who had the entire colon and rectum down to the dentate line removed, and you can see the severe disease in the left side going up through the rectum to the rectosigmoid area, where there is a stark cutoff of which proximally the colon is completely normal. This is a subtotal colectomy specimen where the distal transection was at the rectosigmoid junction, and you can see a complete right at the mid-transverse colon. That's the cutoff. This is very classic of ulcerative colitis. The clinical presentation of the disease relates to the extent and location. Most commonly, patients will have painless passage of blood or mucus with their bowel movements and then develop crampy abdominal pain. More severe episodes are associated with weight loss. That's multifactorial. It's largely food aversion because they know that food in equals more bowel movements out, so they will refrain from eating. But additionally, there's a lot of water, hydration, and protein wasting associated with the sloughing of the colonic mucosa. When patients get really ill, they'll have systemic symptoms of tachycardia, fever, elevated white count, inflammatory markers such as sed rate, CRP, and even fecal calprotectin, which is a newer marker that is very sensitive for ongoing colonic inflammation. Back in the day, there was a disease severity index that was put together by two doctors named Truelove and Witt. This was a very reliable measure to categorize patients' disease into quiescent, mild, and severe based upon the number of bowel movements, the amount of blood in the stool, fevers, their heart rate, their hemoglobin level, and their sed rate. And this was a large predictor of whether or not the patient would be recommended for surgery or ongoing medical therapy, which was very important. This is close 50, 60 years ago, where the only medical therapy that was really available at the time were steroids and some antibiotics. The endoscopic features of ulcerative colitis are quite classic. Early on, you'll get some edema and erythema of the colonic wall with loss of the vascular markings, and that you can see here in this panel. Intermediate, you'll get some granularity and friability and bleeding, meaning very easily the scope just basically brushes up against the mucosa and it starts to bleed. And you might even see some micropurulence coming out from in between colonocytes. In advanced disease, you'll get gross ulcerations where the mucosa is completely denuded away, and you'll develop what's called mucosal bridging. That was actually seen in this picture right here, where there are large islands of mucosa that is completely denuded away, and what you see here in the remaining area where mucosa is attached, it looks like mucosal bridging. Some of the areas of mucosal bridging will develop into pseudopolyps, which are benign but can look very worrisome, and you'll just have frank purulence coming from the colonic lumen. Histologic features, I think it's important to point out here, is that there is nothing pathognomonic for ulcerative colitis as there is in Crohn's disease, where 40% you will find a granuloma, and that is pathognomonic for Crohn's disease. In ulcerative colitis, you will have features that are very suggestive, but nothing 100% definitive. Hence, there is about a 3 to 5% diagnostic dilemma between patients who clinically have colon-only disease, which may be ulcerative colitis or Crohn's disease. The initial medical therapy will essentially be the same, but if and when it came time to undergoing surgery, knowing the difference between Crohn's and ulcerative colitis obviously is very important. But in early disease, you'll see mucosal inflammation. This is kind of hard to really interpret because a lot of this is endoscopic biopsies, which would only be grabbing mucosa anyway. So unless you had a surgical specimen where you were looking at all the layers of the bowel wall and you saw mucosal only inflammation, that would help guide you towards ulcerative colitis. But early on, you'll get crypt distortion, goblet cell mucin depletion, and vascular congestion. With intermediate disease, you get uniform crypt abscesses. Yes, you can get crypt abscesses in Crohn's disease as well, but it is more prevalent in ulcerative colitis. You get loss of mucosa with retention of the crypts, and then you get a neutrophilic infiltration within the lamina propria now that the mucosa is gone. In advanced disease, you get complete crypt destruction, deep submucosal inflammation, and the pseudopolyps and mucosal bridging like we talked about before. Dysplasia, even in the setting of completely normal looking colon and colonocytes with no crypt distortion or crypt abscesses, is also considered to be advanced disease. Let's talk about the extraintestinal manifestations of ulcerative colitis. This occurs to 15 to 20%, 25% of all patients with UC. And the extraintestinal manifestations are divided into those that parallel colonic disease and those that are independent of colonic disease. Meaning those that parallel colonic disease, if you successfully medically or surgically treat the colon disease, you would expect that the extraintestinal manifestation would also improve. And if it's independent of colonic disease, then regardless of medical or surgical therapy for the colon, that extraintestinal manifestation can continue. So ankylosing spondylitis and sacroiliitis associated with the HLA-B27 parallels disease. This happens between 1 and 6% of patients. Skin lesions such as pyoderma gangrenosum and erythema nodosum, which have some very classic findings, and I'm sure we've all seen them, will parallel disease. That's why they do respond to therapy including our immunosuppressive therapy and or the removal of the colon. The hypercoagulable state is usually during the state of the heightened colonic inflammation. So if that is decreased either with medical or surgical therapy, the hypercoagulable state will also abate. The diseases that are independent of colonic disease, the extraintestinal manifestations that are independent, are things like the peripheral arthritis, hepatobiliary disease, which is almost exclusively primary sclerosing cholangitis, but also primary biliary cirrhosis, and the ocular manifestations. These diseases will continue despite proper medical therapy and or surgical therapy for the colon. The natural history of the disease is characterized by acute flares and periods of remission. At any given time, 50% of patients are relatively asymptomatic, and 50% of the time, patients have mild to severe symptoms. And if you really think about that, you're essentially saying that 100% of patients are having some form of symptoms at any given time. Patients with inflammatory bowel disease are extraordinarily resilient and learn to tolerate certain symptoms because when it's not that bad, it's good enough. But it is very difficult to achieve complete remission with medical therapy or even surgical therapy. The cumulative probability of remaining completely asymptomatic is 20% after 2 years and less than 5% after 10 years. This essentially means that the vast majority of patients with ulcerative colitis are going to have some pretty significant symptoms at some point during their life. 20% of patients with ulcerative colitis will have at least one severe attack that will require hospitalization. This is important because back before the era of biologics, 10 to 30% of patients who got admitted to the hospital with a severe attack of ulcerative colitis required surgery within 1 year, if not that index admission. And 80% of these patients at 10 years required an operation. Nowadays, in the era of biologics, and there are more and more that are coming out, a lot of these patients are keeping their colons longer. But overall, while medical therapy is effective, 30 to 40% of patients will eventually still require to have a colectomy. So let's look at the morbidity and mortality of the disease. Historically, this was a very morbid and deadly disease. The risk of dying from the first severe attack, this is typically patients presenting with toxic megacolon, there was a 1/3 chance of dying. And this was largely because it was not recognized that the surgical removal of the colon, or even the ability to safely surgically remove the colon, would save the patient. And if a patient was lucky enough to have their symptoms be tolerable and live long enough, the mortality rate was very high because of the high incidence of developing cancer long-term associated with their ulcerative colitis. Modern treatment is divided into medical and surgical. The medical therapies are the immunosuppressive agents that are divided into inducing agents, meaning trying to induce remission, and maintenance, meaning maintain remission. And the goal of treatments of medical treatment is to control symptoms. The goal of medical therapy is not to cure the disease. Currently available medications are not curative for either the intestinal or extraintestinal manifestations of ulcerative colitis. The surgical treatment is the removal of the entire colon and rectum. The goal of surgery is to cure the disease, and by doing that, you will also be able to cure some of the extraintestinal manifestations. In terms of the medical therapy and inducing therapy, that to induce a clinical and endoscopic remission, the type of therapy is chosen based upon the anatomic extent of the disease and the clinical severity. It used to be thought that we would do a bottom-up approach where you would start with some mild medical medicines like the 5-ASA mesalamine compounds, or even some intraluminal steroids like budesonide. But nowadays, we're actually seeing for anybody who develops some pretty clinically significant UC at an index of their presentation might go straight to biologic. Maintenance therapy is initiated once clinical remission is achieved, and this is also corroborated by endoscopic surveillance of the colon. If you try to put somebody just on maintenance therapy without appropriately achieving remission, that is a virtual guarantee relapse of their disease process. And the medications for maintenance therapy are largely the same as those that can be used for induction therapy, except for the antimetabolites, things like Imuran and 6-MP. And that's because these medications take several weeks to months to become effective based upon the pathway of how they work. But they're very good for maintenance therapy. So the pros of medical therapy is that you can decrease and control the symptoms of ulcerative colitis. You can avoid surgery, which is very important for patients because they fear surgery, they fear ostomies, they fear losing their colon. They just view surgery as the antithesis of everything that is associated with healing. Long-term remission is definitely possible in the vast majority of patients, more than 60 to 70% of patients. But there are a lot of side effects to the medical therapy, and we've all seen some of these, whether no matter what the medications are, particularly the steroids. Cost associated with the medications is very high, often requires a lot of insurance approval. A lot of times insurance companies will actually not approve validated and warranted medical therapy simply because of the cost. You will need ongoing continued surveillance with colonoscopies, usually on a yearly basis, not just to look for cancer, but also to check on mucosal healing and the efficacy of the medical therapy. And as long as you keep your colon and have any degree of inflammation, your risk of malignancy is still higher than that of the average population. Surgery for ulcerative colitis, again, as we discussed, despite the advances in medical therapy, which is truly remarkable with the amount of biologics that have come out since the mid-1990s, the colectomy rate has essentially stayed the same for the last 30 years. So even with all of these new medicines, the colectomy rate has stayed the same. It is presumed, however, that we are allowing patients with ulcerative colitis from the time of diagnosis to the time of surgery to stretch that time period out, meaning they might respond to a biologic therapy and live through their teenage years into their 30s with relatively good quality of life. We're still seeing overall, however, that upwards of 30% to 40% of patients will eventually have their colons taken out. The surgical history, when it was first realized that this was a surgical disease where the removal of the colon and rectum completely would cure the disease, that became the gold standard operation, a total proctocolectomy with an end ileostomy. And what that looks like is the separation of the terminal ileum from the colon, removing the entire abdominal colon and the rectum down to the anal musculature, and the creation of a standard Brook ileostomy. Understandably, back in the 50s and 60s and even 70s, once this was recognized to be a surgical disease or have the ability to have a cure, this was not a very desired operation for patients in their 20s and 30s or even younger with the knowledge of having that they would have to have a permanent ostomy. Additionally, during this time, we didn't really have the advent of WOCNs and the ability to really manage ostomies. So ostomies were actually truly terrible back during this time, but your disease was cured. Later in the 1960s and 70s, when WOCNs became more prevalent and appliances were made to control the leakage, it wasn't so bad. That being said, in the 1960s, Dr. Nils Koch, a surgeon from overseas, came up with what's called a continent ileostomy, otherwise known as a Koch pouch. And this technique was brought to the United States of America by Dr. Erwin Gallant, who flew overseas to work with Dr. Koch and learn the procedure. And he did the first Koch pouch at the United States of America at the Mount Sinai Hospital in 1970. Dr. Gallant was one of the founding members of the group that I initially was in while at Mount Sinai. This is a schematic of how Koch pouch is created. You're taking a loop of the end of the ileum. This is what's going to become the os that comes out through the skin. You're going to create a common channel amongst these three folded limbs. Before the advent of staplers, this was all hand sewn. You're then going to intussuscept this outflow tract inside the pouch, and using various forms of fixation devices. This being shown here is a linear stapler that is a non-cutting. So what it does is it staples this intussuscepted lumen to itself to prevent it from desuscepting or going back out. So you have a valve now that is inside the pouch, which you then close over the top. So the patient has an os at the skin level. It does not need to be sticking out the way that a bronchioleostomy does. It can be flush with the skin. It's completely continent, where no stool or succus would leak out. The patient doesn't need to wear an appliance. They can just wear a Band-Aid over top of the opening at the skin level. And several times a day, they take a rigid catheter, place it inside the pouch, which overcomes the continence of the valve, and they would irrigate and empty the output. And this was considered by a lot of patients and a lot of surgeons to be much better than having a standard bronchioleostomy. This is a procedure that is done in decreasing frequency over the last few decades, and my involvement in working with these is exclusively in revisional surgery because, unfortunately, these procedures were fraught with complications. But this is what it would look like with a continent ileostomy or a cock pouch, where you would have an internal reservoir with an ostomy on the outside that would not drain stool unless you put a catheter in it. Often these were hidden low down in the inguinal crease or by below the bikini line, so the patient's abdomen didn't have any exposed mucosa. Moving on to iliopouch anal anastomosis, which is now considered to be the procedure of choice because this will allow patients to have intestinal continuity and continue to have the ability to eliminate feces from the anal canal. This was initially popularized by Dr. Parks and Nichols in the late 1970s with the creation of S and W pouches. And again, this has the benefit of removing the diseased colon and rectum while preserving fecal continence. This is a schematic of an S pouch. It looks very similar to that of a cock pouch. And what you have is you have the end of the ileum at the bottom. You're going to create a common channel out of these three-folded loops of ileum, and you're going to then suture this end of the bowel to the dentate line, and then that is going to be your pouch. A W pouch is simply one more fold of the ileum, so it's slightly larger, and instead of the end of the ileum being sutured to the bottom, you have the an antimesenteric portion of a loop being then sutured down to the dentate line. And conceptually and functionally, these worked pretty well, and patients were quite happy. Unfortunately, due to the size of the pouch itself, over time, these would stretch out and they would raise up out of the pelvis, and patients could develop obstructive defecation and difficulty with elimination. Oftentimes, even with the S pouch, this portion here can often be kinked off, and patients ended up having difficulty with defecation. And so in the early 1980s, a Japanese surgeon named Utsunomiya came up with the J pouch procedure, and it's the same concept. It's just a smaller pouch altogether, where you're going to fold a loop of the end of the ileum, usually between 15 and 18 centimeters long. You're then going to create a common channel between the two of them, and the final result is going to be a doubly wide lumen or a J reservoir that would then be brought down to the anal canal. Now, for historic purposes, although this is still done today, and I still perform this procedure routinely, in order to remove all of the disease at risk, you'll need to strip the mucosa from the dentate line up to the end of the rectal cuff. And in order to do this, it's a very challenging procedure in order to preserve the internal anal sphincter. And then you would pull through. That's where the term pull-through procedure came from. You would pull the J pouch down and through and suture the J pouch to the dentate line. And what you can see here is the anatomy of where the anastomosis is all the way down at the dentate line. Again, technically challenging procedure. It was thought necessary in the beginning because you're removing all of the disease at risk, so patients would not develop cuffitis, which is ongoing inflammation from their proctitis from that segment, and also thought to decrease the likelihood of malignant transformation. With the advent of the EEA stapler, this procedure became a lot easier to create a good functional anastomosis, as you can see here. The difference being is that the anastomosis is at the top of the anal rectal ring, not down by the dentate line. So you are leaving a patient with anywhere between 1 and 3 centimeters of colon mucosa that is at risk for ongoing inflammation, the colitis, and potentially malignant transformation. It is important to comment at this time that in the history of performing J pouch or S pouch or W pouch, any ileopouch anal anastomosis procedures, there have been less than 100 total cases where patients have developed rectal cancer. But interestingly, it is an even split between those who've had a double staple technique versus those who had a mucosectomy and a hand-sewn anastomosis. So the procedure of a mucosectomy is not done to decrease the cancer risk. It is more to reduce the ongoing inflammation that some patients can have with colitis. It's also important to recognize that the other technical challenge with a mucosectomy procedure is that you need an extra 2 to 3, 4 centimeters of length in order to get the pouch to reach down to the dentate line, compared to a double stapled where you're stapling much higher up and you don't need as much length. I would say that more than 90% of J-pouch procedures done in the United States today are being done via the double stapled technique. The end result is that the entire colon and rectum are removed, the J-pouch is created, and then typically 20 to 30 centimeters upstream, a diverting ileostomy is created so that there's no stool that will flow through the pouch and create any potential risk of leakage. It's important to recognize that a diverting stoma doesn't prevent leakage, it just prevents the ramifications of leakage. You will not get as sick if you're just leaking mucus compared to if you're leaking stool. 2 to 3 months later, sometimes sooner, sometimes later, based upon convenience, you'll do a retrograde study, gastrograph and enema, or a CT pouchogram. You'll confirm that the pouch is completely healed. You'll watch contrast reflux back into the ileostomy so that you know that there's no distal obstruction as well. And when that looks good, you'll reverse the ileostomy. So the indications for surgery are divided into those that are emergent and elective. In emergency situations, we have fulminant disease unresponsive to maximal medical therapy. Those are our patients with toxic colitis. Perforations, which include perforations during colonoscopies, especially if those were patients who had pretty significant disease at the time of the colonoscopy. If you have life-threatening hemorrhage requiring ongoing transfusions, not responding to maximal ICU care. In elective situations, you can have patients who are completely asymptomatic. They just have a screening or a surveillance colonoscopy that finds a cancer. You might have complications or intolerance to the medical therapy, and therefore your disease activity continues. Again, disease activity refractory to the medical therapy. You could have disabling extraintestinal manifestations of the ones that we said that paralleled the colonic disease. And in children who are still growing, if they're not able to get their nourishment because of how ill they are, they can have permanent growth retardation, and surgery is definitely indicated in those patients. So the common surgical practice is in an emergency situation, usually we're going to do a 3-stage procedure. And what that means is that in the first stage, you're going to remove the entire colon. Now, whether you call it a subtotal colectomy or a total colectomy, what you're referring to is the removing of the abdominal colon, transecting right at the rectosigmoid junction. You're leaving the rectum in place, and you're going to create an end ileostomy. These operations are done open, laparoscopic, robotic, single port laparoscopic, which happens to be my preference, through the stoma site. But whatever it is, you're removing the 80% of the colon in a disease at risk, and you're creating an ileostomy. This allows the vast majority of patients to restore to health, to recover, to come off of all of their immunosuppressive medications, and then at a later time, in a second stage, you would go back to the operating room, you would remove the rectum, you would create the J-pouch, and most commonly create a diverting ileostomy again. And then a couple of weeks to months after that, again, after doing a retrograde study to prove that the pouch is healed, you would do an ostomy closure. In elective situations, you're often able to do a two-stage procedure. And this is in the first procedure doing the total proctocolectomy, so the removal of the entire colon and rectum with creation of the pouch and a diverting ileostomy. Again, restore the patient to health, recovery, withdrawal from medications. And then in a second procedure doing the ostomy closure. It's important to note, this is an observation of my own, but it has also been studied and it's in the literature now, with the advent and the continued medical therapy that is coming out these days. We are finding, the surgeons and gastroenterologists, we are finding overall that patients are holding on to their sick disease colons longer and longer and longer while they are trying different medications, and they're becoming sicker and sicker and sicker by the time they come in for surgery. And so even though it might not be an emergency situation, you're looking at a patient with an albumin less than 2 who's lost 60 pounds leading up to their final decision to have surgery, and there's just no way you're going to create a pouch at that time. You'll do a 3-stage on a person like that. The short-term morbidity, the most common is small bowel obstruction. This is whether or not you do a subtotal colectomy or a total proctocolectomy with a J pouch, and that's because you have a tremendous amount of raw surface in the area of where you've removed the colon, and the small bowel will fill those spaces and obviously is at risk for obstruction. Additionally, an ostomy, whether it's an end or a loop, is an independent risk factor for development of a bowel obstruction. Strictures at the IPA anastomosis are extraordinarily common. We'll talk about that a little bit later, but it's usually while the patient is diverted and is easily remedied simply by taking the stoma down and allowing the patient to functionally use their J pouch. Bleeding certainly is a risk. Leakage can occur from the rectal stump. If you think about it, you're stapling across a diseased segment of bowel, and sometimes those staples or sutures don't hold properly, but you can also have pouch leakage, which can, both of these lead to pelvic abscesses. And mesenteric thrombus is another consideration that we always have to remember in the early post-op period for our patients with ulcerative colitis and their hypercoagulable state. Often they'll present with nonspecific abdominal pain, maybe very high ileostomy output, maybe fevers and nausea. You're getting a CAT scan because you're expecting to see a leak or pelvic abscess or something, and what you'll find is clot burden within the superior mesenteric vein or a branch of the portal vein. Usually these are small, they are not flow limiting, and by starting anticoagulation, all of their symptoms will go away completely. Unfortunately, there are a certain percentage of these patients where the occlusion of the SMV is so much that you have complete venous obstruction of the small bowel, and IR often needs to do procedures to try to dig out that clot. Otherwise, patients are at risk of losing large amounts of their small bowel. It can be quite terrible. And it's just a plug that all of these patients should be on pre-op. They should get pre-op heparin and be on TID heparin postoperatively. I will send all of my ulcerative colitis patients home on daily Lovenox shots for upwards of 30 days post-discharge. The long-term morbidity, again, small bowel obstruction is up there. Pouch fistulas occur. We'll talk about that a little bit differently a little bit later because pouch fistulas can be due to technical failures of pouch creation, but can also be Crohn's disease. Pouch dysfunction is happening less and less frequently now that the procedure has become more and more refined. This simply just means that you've created technically a perfectly appearing pouch. It just does not work, and the patient does not enjoy good bowel function. Pouchitis is very common. We'll talk about that a little bit more in a second. Sexual dysfunction in men occurs because of the surgery around the rectum, much the same as doing rectal cancer surgery. You're around the hypogastric plexuses as well as the nerve erugentes down in the pelvis, and if you are not in the correct plane and you injure these nerves, patients can end up with complete impotence or retrograde ejaculation. And in women, the scarring in the pelvis associated with proctectomy can lead it to become more difficult for them to become pregnant because the sperm have challenges meeting the egg through a externally scarred or twisted fallopian tube. The overall ileopouch anal anastomosis morbidity, the numbers, depending on how you look at it, are either very low or very high. Mortality tends to be very low, and this is largely because patients are quite young and otherwise healthy. We're talking about teenagers through 30 years old and usually don't have a lot of other comorbidities. It's important to note, however, that sometimes when patients get very, very ill with their disease at the time of requiring surgery, that is the singular most important factor leading to mortality at the time of surgery. Pouchitis is the most common complication after J pouch creation. It is a inflammatory condition of the pouch. It is immune mediated. It is bacterial mediated, but it's largely still unknown. There are genetic predispositions to it as well. It is more common in men. It is more common in patients with PSC, and it's more common in the first couple of years after pouch creation. In my mind, I feel that it's because you're now having bacteria in stool that doesn't normally reside in the ileum that is now residing in the ileum, and it's leading to inflammation. Symptoms are of new onset watery diarrhea, often with incontinence, crampy pain, and fevers, and almost always responds to medical therapy. Most commonly is Flagyl. Cipro works as well. The long-term usage of either of those is not so great. There's new evidence that certain probiotics and other therapies can be very helpful. For patients who still have a rectal cuff in a double stapled anastomosis, it's important to distinguish the differences between pouchitis and cuffitis because you would treat that differently. Cuffitis often is managed very easily with Canassa suppositories. Anastomotic strictures are extraordinarily common. Again, this is almost always when the patient is diverted. So you have a diverted J pouch. You go and you go to reverse their reverse their ileostomy. You put them in lithotomy. You stick your finger in to dilate. You will feel a web-like stricture, and you'll do a pouchoscopy to confirm that the pouch looks good to you, and that counts as an anastomotic stricture. But the amount of patients who will manifest a clinical anastomotic stricture, meaning obstructive defecation or requiring digital dilation, either self-digital dilation at home or requiring repeated trips to the operating room to dilate, is probably less than 5%. Small bowel obstruction, we talked about. Pelvic sepsis, early and late, we talked about. Anastomotic separation, we kind of mentioned. This is when a J pouch might separate from the anastomosis. Sometimes these things happen in a delayed fashion or in an asymptomatic fashion because you have an ileostomy above it, so nothing is leaking out. Oftentimes these are found on the retrograde study that you do to prove that the pouch is sealed, and this is largely due to tension on the anastomosis, which is a little bit beyond the scope of the topic of this conversation in order to get length and reach, but something I'm happy to talk about at a later time if there's interest. Pouch vaginal fistulas occur upwards of 10% of the time. I'd like to believe that it's less than that, but these can occur for various reasons. Number one, you have a fresh pouch with numerous staple lines on it that is sitting directly on the back of the vagina. But you can also inadvertently with an EEA stapler, especially that low down with poor visualization, catch the posterior wall of the vagina in the EEA anastomotic stapler and create a fistula that way. And then lastly, it's important to recognize that Crohn's disease can manifest as a fistula, and 3 to 5% of patients who were initially characterized and clinically completely had ulcerative colitis will manifest Crohn's disease clinically by simply developing fistulas after their ileostomy is closed. Incontinence is quite rare. It's initially in the beginning, the first couple of weeks to months. This is due to the loss of the receptive ano-inhibitory reflex and the loss of discrimination of stool and gas, primarily when patients are asleep, but universally long-term. This is not usually a problem. This includes patients who had these operations decades ago and are now in their 80s, 70s, 80s, or 90s and enjoy perfect functional control without incontinence. We talked about the decreased fertility for men and women. And overall pouch loss is between 5 and 8%. And the number one cause for pouch loss is the manifestation of Crohn's disease in the pouch that can't be temporized by drainage of pelvic sepsis or reinstitution of medical therapy, and the patient will choose to go to an ileostomy. The postoperative expectations is that you would have between 6 and 8 bowel movements per 24 hours. with the majority of them during the day where you can sleep through the night. Obviously, this depends on how much you eat before you go to sleep at night, but that you would have perfect control. So if you take a colitic who has between 20 and 30 bowel movements a day and you tell them I can have you have only 6 to 8 a day with perfect control, they'll say, sign me up in a heartbeat. But if you take a ulcerative colitis patient who only has 1 bowel movement a day but is found to have a cancer, and then you're talking to them about a J-pouch operation and 6 to 8 bowel movements a day, they're not too enthused about that. So depending on how you look at it, it is what it is. The way I look at it and I explain it to my patients is, for men and women, we usually empty our bladder between 6 to 8 times a day and maybe once or twice overnight. And instead of just standing up, if you're a man, you just sit down and you empty whatever's in your pouch. So it's no extra time spent, but it is more frequent than what you would consider to be a normally functioning colon and rectum. So the summary of surgical therapy, the pros is that it is curative, okay? It cures your disease. It relieves all of your symptoms. It removes almost completely the risk of malignancy. We touched on that a little bit earlier. There's no need for medications. There's no need for surveillance colonoscopies, and overall improved quality of life. I'd like to just comment right here, though, that there's also been numerous studies that have done before and after the era of J-pouch procedures. So if you looked at population-based studies of thousands of patients who had total proctocolectomy with a permanent end ileostomy, more than 93% of patients will rate themselves as having a high quality of life and would absolutely do that operation again. And the numbers for those patients with a J-pouch who don't have to live with a permanent ileostomy is about 96%. So it is not the ileostomy or the lack of an ileostomy that really imparts the quality. It's simply the abating the negative symptoms of the inflamed colon and the frequent bowel movements and the lack of control and just feeling ill. The cons of surgical therapy, obviously, is the morbidity and mortality associated with the procedures. These are big operations, and often the first operation, you're operating on somebody who is very sick, very immunosuppressed, very malnourished, and at risk for infections and lots of complications. Despite me promoting how curative the surgery is, patients need to keep in mind that there are permanent lifestyle changes resulting from the surgery. 6 to 8 bowel movements a day for certain people just is not conducive to what they would consider to be curative. Videos of these surgeries, I have many up on my own YouTube page, which is featured here, so feel free to visit. You're also welcome to join many of the closed Facebook groups, whether it's through SAGES or other societies, where we share cases and show instructional videos of these procedures, the subtotal colectomy, single port subtotal colectomies, J-pouch procedures, and whatnot. All available there. Thank you very much for listening to this lecture. I hope that this properly helped you fill some time during these unprecedented times in our world right now. I'm happy to take any questions and answer anything and ongoing conversations via email, which you can see here. Thanks again, and a big shout out and thank you to Dr. Eric Poli for coming up with this initiative for all of our benefit.